as Amlodipine.
And my name is Diltiazem, and we are the calcium channel blocker sisters. For my drug name, my generic name is Diltiazem hydrochloride. For my brand names, there are many: Contraindications, Dilacor, Diltiazem, etc. And for my sister's drug name,
My generic name is Amlodipine, while my brand name are Norvasc, Amvas, and Cateriza. My drug classification and therapeutic are anti-anginal and anti-hypertensive, while in pharmacologic is the hydropyridine calcium channel blockers.
and for my drug classification, for my therapeutic classification is for anti-hypertensive and vasodilating properties. And for my pharmacologic classification is calcium channel blockers.
My pregnancy category is category C, and amlodipine should not be used during pregnancy only if the potential risk to the fetus.
And for my pregnancy category, same goes with my sister, pregnancy category C. Animal studies have shown an adverse effect on fetus, but there are no adequate studies in humans.
My mechanism of action is first as consider a peripheral arterial vasodilator that exerts in action directly on vascular smooth muscles that lead to reduction in peripheral vascular resistance, causing a decrease in blood pressure. Second, a vascular smooth muscle contraction initiates when calcium enters the cell, a voltage-dependent L-type calcium channels. Third, the calcium binds to and activates light chain kinase. Fourth, is responsible for the phosphorylation of mucin light chain and ultimately leading to muscle contraction and vasoconstriction. Fifth, is works by blocking the voltage-dependent L-type calcium channels, inhibiting the initial influx of the calcium. Sixth, is revealing stable angina due to lowering of afterload secondary to its vasodilatory and antihypertensive properties.
And for my mechanism of action, I primarily work by inhibiting the calcium influx into cardiac and vascular smooth muscle during depolarization. So excitation of cardiac muscle involves the activation of a slow calcium inward current that is induced by L-type slow channels, which are voltage sensitive, ion selective channels associated with the high activation threshold, and a slow inactivation profile. I reduce intracellular calcium concentrations, equate to increased smooth muscle relaxation resulting in arterial vasodilation and therefore decreased blood pressure. For the pharmacokinetics, I am absorbed orally or intravenously, but I am readily and well absorbed from the gastrointestinal tract and is subject to extensive first pass effect, giving an absolute bioavailability compared to when I am taken intravenously of about 40%. So again, when we say bioavailability, this measures the extent of the drug of me being absorbed. So the bioavailability may increase in patients with hepatic impairment.
That I absorb slowly and almost completely from the gastrointestinal tract, where peak plasma concentrations are achieved by 6 to 12 hours after the oral administration. So my estimated bioavailability is about 64 to 98%, where steady state plasma levels achieved after the 2 to 8 days of consecutive daily dosing. So therefore, my absorption is not affected by the food label.
For the distribution, I am distributed of about 70 to 80% bound to plasma proteins, according to in vitro binding studies.
In distribution, I'm about 95% of the circulating drug is bound to the plasma proteins in hypertensive patients.
For the metabolism, as what I've mentioned earlier, I am a subject to extensive first pass metabolism, which explains its relatively low absolute oral bioavailability. So I undergo metabolism primarily mediated by the cytochrome P450 system of enzymes. So that is an important enzyme found in the body, mainly in the liver and the intestines, which oxidizes small foreign organic molecules such as toxins or drugs so that they can be removed from the body.
In metabolism, IAM extensively metabolized in the liver where there is no significant pre-systemic or first-pass metabolism and slowly cleared in a terminal elimination of half-life at 40. So,
for the excretion, again, due to its extensive metabolism, only 2 to 4% of the unchanged drug can be detected in the urine.
So elimination, I eliminated from the plasma that occurs in biphasic with the terminal elimination half-life of about 30 to 50 hours, and my steady-state plasma levels are reached after the 7 to 8 days of consecutive daily dosing, and for about 10% excreted as unchanged drug in the urine and initiated at normal doses in patients diagnosed with renal failure.
So for the indications, when I am taken orally, I am indicated with clients with patients who have angina or hypertension. So for those who don't know what is angina is a type of chest pain in which there is reduced blood flow going to the heart, so constricted ang blood vessels. So when I am taken intravenously, I am indicated for emergencies.
My indications, first in hypertension, I am a double-blind placebo-controlled where placebo-corrected reductions in supine and standing blood pressure for about 24 hours after the administration. And in coronary artery disease, I am a chronic stable angina and transmental angina variant or vasospastic angina, and I am also CAD determined by angiography in patients without heart failure or ejection fraction less than 40%.
Now for the contraindication. I am contraindicated with patients who have sick sinus syndrome, except in the presence of a functioning ventricular pacemaker. Second, patients who have second or third degree atrioventricular block, except in the presence, again, of a functioning ventricular pacemaker. Third, patients with hypotension, less than 90 milligrams of mercury systolic. Fourth, patients who have demonstrated hypersensitivity to the drug. And lastly, fifth, patients with acute myocardial infarction and pulmonary congestion documented by X-ray on admission.
My contraindications, so I am contraindicated with patients with hypersensitivity to the hydropyridines or any of the excipients such as the cellulose microcrystalline, salica caudal anhydrous, sodium starch glycolide, and magnesium stearate. I am also severe hypotension and shock, including the cardiogenic shock.
Now for the side and adverse effects. So when I am taken orally, I do not cause drowsiness. However, I can cause other side effects, and this includes headache, dizziness, slow heartbeat, fluid buildup or swelling, weakness, nausea, and rash. And for the adverse effects in relation and in heart-related problems, I can slower the normal heart rate and worsen chest pain. And for liver problems, I can cause the yellowing of the skin or the whites of the eyes, dark colored urine, and upper stomach pain. For skin problems, I can cause swelling in the face or tongue and red or purple rash that spreads on the skin.
My side and adverse effects in cardiovascular system is that chest pain, myocardial infarction, and arrhythmia, and I cannot distinguish from the natural history of the underlying disease. In nervous system is that somnolence, dizziness, and headache. This is common side and adverse effect, while the uncommon side and adverse effect is that tremor, taste perversion or dysgeusia, syncope, hypoesthesia, and paresthesia. In gastrointestinal is that abdominal pain and nausea. This is common side and adverse effect, while The uncommon are the vomiting, altered bowel habits, and dry mouth. And dermatologic is that flushing, skin discoloration, increased sweating, hyperhidrosis, pruritus, and rash exanthema. Erythema multiforme, urticaria, exfoliaria dermatitis, and Steven-Johnson syndrome, and cold and clammy skin. In genitourinary is that microturation disorder, nocturia, increased urinary frequency and impotence, and musculoskeletal is that arthralgia, myalgia, muscle cramps, and back pain. And respiratory is dyspnea, rhinitis. In ocular is that visual disturbance, abnormal visual accommodation, and xerophthalmia, while endocrine is that gynecomastia, and hematologic is purpura and leukemia thrombocytopenia.
Now for the nursing responsibilities. Before administering me and my sister, assess the appropriateness of the medication practices by considering the patient, the medication, us, and the environment. Second, assess for the cautions and contraindications as mentioned earlier to prevent any untoward complications. Third, provide teaching points about the do's and don'ts, when taking the drug, taking us, by swallowing extended release and long-acting preparations whole. Do not cut, crush, or chew the us, and do not drink grapefruit juice while taking us. Discuss with the patient the possible side effects with the drug and gain verbal consent upon administering us. And lastly, administer medication orally.
During as you have to monitor the blood pressure for therapeutic effectiveness. BP reduction is greatest after the peak levels of amlodipine are achieved to 6 to 9 hours following the oral doses. Second is you have to monitor for the signs and symptoms of doses-related peripheral or facial edema that may not be accompanied by weight gain. And third is you have to monitor the blood pressure with postural changes, report postural hypertension, monitor more frequently when additional antihypertensive or diuretics are added. And fourth, you have to monitor the heart rate and dose-related palpitations that may occur commonly in women.
And after, notify the physician of any irregular heartbeats, shortness of breath, swelling of the hands and feet, pronounced dizziness, and constipation.
Then, establish a risk management plan to ensure that the potential risks are recognized and minimized.
And that would be all. Again, my name is Diltiazem,
And my name is Amlodipine, and we
And
are
we
the
are the
Caution
Caution
Channel
Channel
Blocker Sisters. We hope you've learned something from us.
Bye!